Hi, thank you guys so much for having me. Thank you so much to Helen and the rest of the UK duplication, MECP2 Duplication UK for giving me a couple of minutes to talk to you guys and honestly ask for help. So I'm Amelia, my son is Everett, he has MECP2 duplication syndrome. I'm also a general pediatrician in the US, and in 2018, my husband, my dad, and I founded the MECP2 Duplication Foundation when our son was diagnosed. There he is. He's my reason for doing all of this, because I will tell you this process has not been fun. It feels very just like beating my head against a wall sometimes. So that's Everett when he is a couple of months old. Before we knew anything was going on, that was a little different. So ICD-10 code, some of you may be familiar with that term, maybe not. It's a standardized code that we use to try to very precisely and accurately describe a diagnosis, because obviously there are hundreds of thousands of diagnoses out there, very complex. ICD-10, International Classification of Diseases, that's what that acronym is for. I'm sorry, ICD, and then 10 is the 10th version or 10th revision. This is actually maintained by the WHO, the World Health Organization. It's used internationally, though individual countries do have modified codes. So specifically the US, we have two modification systems. We have the ICD-10-CM for diagnosis codes, and then we have the ICD-10-PCS, the procedural code system for inpatient medical procedures. Within the UK, within Europe, typically you are using just the plain old, the original ICD-10. Canada has the ICD-10-CA, and then Australia has the ICD-10-AM, so the Australian modification. And essentially, it's a shorthand label to be able to convey or query a diagnosis. It's made up of letters and numbers to classify a condition, and they can be very complex. So, for instance, autism spectrum disorder is F84.0, Rett disorder is F84.2. So you can see they lump them into kind of groups. So Rett disorder, it's a neurodevelopmental disorder, obviously paired close to ASD or autism spectrum disorder. Then there are acute respiratory infection unspecified, so J06.9. So that's something that, you'll see, again, similarly grouped diagnoses within those similar codes. And then they use some letters at the end to even further describe what was going on with that patient or that encounter. So for instance, unspecified fracture of the shaft of the right tibia, initial encounter for closed fracture, S82.201A. And then if you're actually coming in for a subsequent encounter, there's actually subsequent encounters and then versus sequelae, then that's D. And then within those numbers, you actually, so say it was the left tibia, or it was an open fracture, or it was, there's all kinds of very intricate changes within that code to very accurately communicate what was going on with that patient. There's Everett when he was his first day of preschool. So how do we use it? We use it in a couple of different places. So we use it within a medical record to clearly document a diagnosis. There are other codes we can use within an EHR, an electronic health record, to communicate a diagnosis. Something called a SNOMED code is something else that we use. We use it in insurance and billing to get paid for something. So there are times my billers will kick back, like, hey, you used an unspecified code and this insurance requires that you say exactly what, you have to say acute cough instead of cough unspecified. So they will look for certain diagnoses to actually pay that physician or whoever for what you've done that day. And then also health statistics. So, we're looking for a very specific rare disease in our kids, right? Where we're trying to look throughout the entire, world. How do you accurately track this medical condition? Because very specifically, there is MECP2 duplication syndrome, right? But then there's also Rett syndrome, which is, a difference in MECP2. But then there's also just, the other kind of differences in MECP2 that we're not all the same. Those kiddos are not all the same. And so again, this is very accurately describing our specific syndrome, MECP2 duplication syndrome. So that helps us with health statistics. So right now, my project is I'm petitioning essentially the United States regulatory committee on this to add a MECP2 duplication specific code to the ICD-10-CM. It's submitted specifically to the U.S. Centers for Disease Control and Prevention, the CDC. I first submitted in 2024. I am at the acknowledgement stage, so there are very defined stages within this process. There's the submission, there's the acknowledgement, there's notification that you've been accepted to present, then there's presentation stage. Then after presentation, so the presentation is to the committee within the CDC that makes these recommendations. And then after that, there's a public comment period where people from around the world can weigh in on why this would be important to our community or why we don't think this should be done. And then there's a final decision by the HHS, which is the Department for Human and Health Services. Within the US, you may be aware, we're having some political challenges changes, and so right now the CDC is kind of on a pause, and so we're sort of in a holding pattern, waiting to hear back on whether or not that we're going to be accepted for presentation. So why is this important? It just sounds like red tape. Why spend our efforts and our time? There's other places we could be spending our energy on, because we don't have a specific code for MECP2 duplication syndrome. The two typical codes that are used are Q99.8, which is other specified chromosomal abnormalities, and Q87.89, which is other specified congenital malformation syndromes not elsewhere classified. So say Davut would like to figure out who within the Texas Children's hospital system has MECP2 duplication syndrome. So he puts in these codes, because that's all we got right now, and it spits out thousands or hundreds of thousands of children that have our syndrome, but all these other syndromes. And so how are we going to identify the people? How are we going to query that successfully and precisely? We're not. There's just no ability to do that right now. So it leads to a major delay in identification of affected individuals. So this puts a lot of barriers. So if we're delaying identification, then we're potentially delaying treatment, we're delaying research, we're limiting the amount of families that we can reach. Everybody in this room is obviously very active in the community. You're here, you saw some sort of social media post or email, but not everybody is. Some people don't like to go in that space because it can be really hard to be on the forum and see some of the harder names. And I mean, we all probably have friends within our community that we know that do not pay attention to that stuff as like a self-preservation or maybe an access thing, right? So how else can we identify people? Hopefully their neurologist gets a notice or went to the CNS, thank you, any of the kind of bigger conferences where their neurologist said, hey, there's this there's this study going on. Maybe I should query my patients and see who's here. Like that's another way we're gonna be able to do that. So those precise codes improve precision therapies. There was a study about seizure management improving if 50% of seizure regimens are affected if we can give a precise reason for their seizure disorder. So having an ICD-10 code could lead to that, right? For clinical trials. So the reason I'm going after Katie and Davut is because there's so much cool stuff in the pipeline for us right now. And we need to be able to identify people within our community that can be affected, that can be helped by this, but then also can help this move forward. And then finally, research. So it's a rare or ultra-rare disease, right? How do we get enough data? How do we get enough kids or adults in these studies to actually have a strongly powered study to actually learn from them? Even some of those studies you were talking about with like an N of 8, how do you make, decisions or clinical management recommendations off that? So if we could get more people into research, we have a rare community, we need to be able to look globally who can be participating in this. But you guys saw that was ICD-10-CM, that's very specific to the US, right? So why would you guys help me? Because this is for the US. We all have very busy days. I feel like some days that one little thing is the straw that breaks this camel's back. And so maybe just filling out my survey is gonna be hard for you guys, but because we are a rare community, and if in the US we can identify more patients, we can get them into research, into data, if we can start understanding our numbers better, then we will have more power globally to have treatments and research. So that would be why it'd be wonderful if you could help. So how can you help? So the foundation has a letter to accompany my submission to the ICD-10 committee. there was a leukodystrophy, and let me just say, I'm so thankful to Christine and to Courtney. Sorry, I don't love talking in front of people. Sorry, guys. They've been helping me by looking at other diseases that have done this successfully, because this is not easy. And if in 5 years I still haven't done this, don't judge me. It's not easy. So there was a leukodystrophy group that did successfully do this, and they shared some sort of insights into how they were able to push this through, and this was from community support and letters, and they had something like 3,000 people sign their letter of support that they submitted with their application, and 150 clinicians. So if we could get as many people to sign on, the more I can show the committee that there is worldwide support and interest in this. So that's our QR code. It'll bring you to something called a JOT form, and it essentially shows you my letter, what I'm submitting on behalf of the foundation, and you can sign your name saying, I agree. We as a foundation, and perhaps even the Global Alliance, will be creating social media posts to reach out to people more than just in this room. So if you could like them, if you could follow us, if you could share them, that would be super helpful, because again, not everybody is here. And then on the JOT form, this is optional. You can just say no thanks in the box, but if you'd be willing to share your email address, I can give you an update if and hopefully when we are accepted and I'm able to present, or are hopefully someone way better at presenting than I can present. When that gets to that stage where we need public comment, if you guys could bombard them with public comments, that would be helpful as well. I mean, this is just, they need to know people want this to happen. And if you are able to do that, that would be super helpful. So adding your email address to the JOT form, I'm not going to use it for anything else. I won't spam you with anything, but I'll put you in my list that I'll shoot out an email and say, hey, we did it. Go in there and tell them how you feel about this. And that's only during the very designated time. So don't go on and start emailing them right now. It's only when I say, hey, it's time, and I'll give you the exact email address to do that. And so that's Everett again. He's really cute. So I thought that I would just put this up here for laughs, because it seems super unfair that bitten by an orca has an ICD-10 code. And MECP2 duplication syndrome doesn't. Walked into a lamppost has its own ICD-10 code. Burned due to water, skis on fire. And a spacecraft collision injuring an occupant. So these all are real-life ICD-10 codes, and we don't have our own. So that's Everett laughing and smiling. Here's the ICD-10 code for what happened to our family 2 months ago, when Everett had a displaced spiral fracture of his left tibia, initial encounter for a closed fracture at the hospital. And this is us at happier times. So please reach out to me if you have any comments or questions or insights, if you've done this before or something. And then that's my email address within the foundation. And the QR code, I made little cutouts and put them on your tables, so please feel free to take those and share those. I have a digital form of it too, but again, it's just it is really quick. It's just putting your name and information, your email address if you'd like. So hopefully it's not that big of an ask, and if you see us posting about this, to share it, because this is a really hard process, and we need as much support as we can. And if you're a clinician sitting here, this isn't just for families. Please, please, please put your name on there. Oh, and then if you're a part of an organization that supports MECP2 families, it is actually helpful for you to write a letter as well that I can submit with my submission. I'll have our co-signatories, but if you guys can put it on your letterhead, I have it written out for you, I can give it to you. If you can put it on your own letterhead and say, and sign it, or whoever is authorized to sign it and send it to me, then again, I can kind of submit that with our packet, just for a little bit more support.
Is there a deadline for it? To sign it?
Whenever our government opens, I don't know. Right now, I'm just waiting for somebody to respond. Yeah. No, I mean, probably within the next month would be lovely. Whoever's contacting me from the CDC, I'm not really sure actually if he's going to be my liaison or not. He's pretty high up within the CDC, so probably not is what I understand. He had said that we would start having further discussions. Essentially, he said, why you guys? There's thousands of distinct genetic disorders. How are we going to do this? Why do I need to talk to you? don't waste my time. And so I have to kind of go in there and petition to him as our next conversation. Here's why. We have all these preclinical things. We have 2 clinical trials. We know we're a strong community. Here's why. Please listen to me and don't just like write me off. So if I could have those by the time he and I talk, and his last email was, once they get through, they do this, these presentations are twice yearly. The last one was in September, and then we immediately closed, and so his email is just turned off because he's on furlough. So, I mean, it's after the September meeting. He's probably gonna be backlogged once his email turns back on. So my hope would be in the next few months. So if you could do this today, that's awesome, but we're gonna really push over the next few months to get these signatures and letters from people. So, cool. Yeah?
What do you make of the emerging relationships with the WHO?
Say that again?
What do you make of the emerging relationships or lack of with the WHO? And how might that affect us?
Personally, no. My hope is it won't affect anything, because they can't just ditch the ICD-10-CM. It's too integrated. There'd be no way to bill, to pay. You wouldn't wipe it from everybody's charts. Like, I don't think this is gonna, my personal feeling is it's not gonna affect this process, because it would be too much time and money, and there's no way that they would well, not no way. In my brain, there's no way that they would ditch the ICD-10-CM codes to go to something else that's America-centric. That's from me. I don't know. Take that with a grain of salt.
I have really good news. It's I've just gone on to Epic, which is an electronic healthcare record. We use at our institution. I think it's the most commonly used one in the US and the UK, probably the UK now. And it's actually on. It's on SNOMED CT, and it's on ICD-10 UK.
UK. So help us be as cool as you guys, because the US doesn't have that. So you guys have a specific SNOMED code, but we do not.
And there's an ICD-10 UK code, which is really surprising. I'm surprised that because I thought it was it's quite internationally standardized ICD, isn't it?
But there's those modifications per
country.
For each place. And so the UK, I actually didn't know that. I knew you guys had your own individual SNOMED code, but that is not translated into the US and other countries.
So that could be an argument that you're creating international inequality.
Right? Let us be as cool as those guys. Yeah, I mean, that's a good point. I absolutely should enter that into my supporting documents. So, yeah.
Thank you.
Katie.
And is it helpful if we were to go to, obviously we're going to have a lot of our PIs and clinicians who work with us regularly will join this, but is it really helpful, like if you go to someone local who is maybe not as familiar with MECP2 duplication syndrome, would it be helpful for parents to ask those providers to sign on?
Totally. So if you took a screenshot of this and showed it to your general pediatrician or your neurologist, that's a great idea. I didn't even think about that. I'm gonna use Davut as much as possible to try and reach out to clinicians within our sphere, but you guys can have way more access to that than I'll ever have. So if you feel comfortable asking your provider to sign this, it truly has no, other than an email address, there's no personal information. It just is asking, or it does ask how you're affiliated with the person, and that's how we can distinguish a clinician from a family member. But if you feel comfortable asking some sort of healthcare provider in your lives, that would be helpful as well.
Yeah. Sorry. So you can go. Sorry, when you're back.
Just a very small question. In Austria, we use, of course, the ECD-10 code, but we also use the OrphanNet code, which codes all the genetic diseases. So this.
Orphan is European.
Yeah. So this wouldn't be a possibility for you because this exists. Make it worldwide, the OrphanNet. In Europe, it's a little bit easier.
That would have to be probably a really big international initiative, and that's not something that we would have ready access to support like the current clinical research and efforts that are going on. I will say that they were looking at, is there some sort of standardized way within the US to start labeling these sort of neurodevelopmental or genetic disorders, but as far as I know, that's not going forward. So right now, as an effort for us, this is the way we can do it, within the US at least, so.
I would also want to comment one thing. If we want to do it worldwide, we have to make sure that we actually code it, because depending on the country, there is a different way to reimburse for the medical conditions. So as an example, in Austria, we don't really get reimbursed for there is a system where you only get reimbursed for the presenting complaint. So if the child is coming to the emergency room because of the constipation is going to be the thing that is going to be coded and reimbursed. Now there are physicians who are really coding all of the diagnoses that the kid has, which is the correct way. Now, because we are overrun by the children, a lot of times we just code the major complaint, like the constipation, and because of that, the child may get lost to somebody who wants to look up the information. So I think this is also one of the things that one needs to keep in mind.
Mm-hmm. Well, it's similar in the US, and I would say from the clinical side, I run into that all the time, where technically I'm supposed to put in fever, cough, congestion, and then my final diagnosis, right?
Exactly.
And that's the best way for me to do it. And then if I have someone who's complex and I'm trying to code a more complex, we use something called a CPT code to ask for money. And if I want to support a more complex CPT code, then if I put something like MECP2 duplication syndrome in there, it'll help me support that a little bit better and less likely to be rejected by insurance. And so honestly, it'll help clinicians support kind of better reimbursement for our more complex kids. It also, I mean, if we're more reliably putting it in there, then when we query a system, right, then we'll be able to pull more kids, because maybe they just went to that one system once because they had an emergency, but they're actually within another system. So, I mean, yeah, and it's just, and that's on the clinician side too, is just making sure we're better documenters. But right now, we don't even have that option.
We heard, well, I heard a lot a couple of years ago when coming to the UK MECP2 conference about Citizen, and that it's only open to US at the moment to sort of download documents to it and sort of it pull back the medical databases in the US. Is there anything in the UK, or is ReMeds looking at that to support sort of globally how we can sort of pull all that information together?
Well, I think Caro can answer that better, but it's my understanding is that's why our individual databases we've had can only go so far as they're individual, and if we can do a more international one, again, that would be so helpful with finding these groups, but that is reliant on people putting their information into those. But so we just would like so many different pathways to grab those patients, because again, what if they're not within the community? What if they're avoiding social media so they don't sign up for ReMeds? Okay, well then maybe their neurologist is going to catch them in their net, or maybe, so it's just having, ReMeds is, while she was talking, I signed my son up. I texted my husband and said, "Did we sign up for this?" And he goes, "I don't know." So anyway, so ReMeds is one way we can do it, because and that's why it stinks, but we're being asked to enter into another database, even though I think personally I've already in 4, some of them are really, really time intensive. Thinking of like the Australian one that took me at least 45 minutes. So yeah, but that's why we're being asked to enter ourselves into that international database, because it's truly international for ReMeds. But this is a different effort to try and have a different net that we just, within the US, do not have yet. And our population base is so big. It's a shame that we don't have a way to sift through our kids' medical records and pluck these kids out to support research and clinical trials and get them the better treatment. Again, if it is well shown that having more tailored, personalized care leads to better treatment. And if say the Ionis, say the ASO, ION 440 does actually get approved, again, then we still have to be able to figure out who to give it to. And if they're not active on social media and they're not active, their neurologist isn't going to these national conferences, how are these families even finding out that the drug is available if it is? So those kids will miss out on huge opportunities. So.
I just think on a personal level, it would help families have something that's a little bit more streamlined to get information. So if you know, my son's hospitalised, everything's sort of on a database in terms of his history, as opposed to bringing in a big folder of information of what's happened with all the appointments you've had, all the scans you've had. And I think Citizen was sort of doing that. So yeah, that was sort of where I was coming from in terms of personally, I struggle when seeing or being in hospital.
Yeah.
It's just having something to draw from very quickly to be able to give to the doctors to make decisions quicker.
Yeah, well, and then also I think then, again, if we can more precisely describe and identify our family members or our affected loved ones with this, then there's more data and research for those physicians to quickly look it up. You know, it just, yeah, I know what I'm doing is not the answer to that. It's part of the equation, and it's part of this next step as we try to get further in clinical trials. I wish I had an answer. I wish we had like one EHR that we were all in one medical system, and they could pull from everywhere we've ever been, and they have all of our data right there, and there's one code for everything, and that's just not reality. But you know, trying to have more precise codes is at least like a step there, at least for our country. So,
thank you.
Yeah.
Oh, thank you. I just want to add here, this is what I mentioned when I said REMEDS is just phase 1 at the moment, but we are thinking to improve it, thinking that it's a really centralized place for families to put their information into when going to a doctor, for example, bringing the report, putting it into REMEDS. Also, having a way for families to track when they had this appointment at the dentist, I don't know, immunologist, so to keep track and even to have reminders for next appointments, because we know we are all busy thinking about our lives, thinking about the kids, when did they get the last appointment, when should I start thinking about the next one. And this is part of the thinking that we are having and seeing how REMEDS can evolve in a couple of months, maybe a year, once we have also enough patients in REMEDS. So.
And just on that note to Citizen, yes, it is going to stay U.S. only. That's just because of rules around accessing healthcare records. So yeah, that will stay in the U.S. But another thing that has come up recently is that for the U.S., and hopefully this would go global as well, is that having this code allows families to participate in other non-genetic studies. Like, I only focused on the genetic studies, right, that are going on and that are hopefully coming along the way. But there is clinical research on on symptomatic aspects of MECP2 duplication syndrome. So like, we're working right now with another company who's doing research on severe seizures, and MECP2 families are going to be included in that. And a great way for them to be able to get more participants in that kind of research, that symptom-specific research, you know, if you were studying something to help with gastrointestinal health or you know, anything around epilepsy, it would be really helpful to be able to query and find out these are families that have MECP2 duplication syndrome. They also have other related codes that make them good candidates that we might want to screen them. We could reach out to them for screening. So we are trying to do that and help make that happen now. It's way harder to do that without an ICD-10 code that they can just go in and look for. So if those things, though, again, the success of that in the U.S. then can go out to the rest of the world, right? If it gets approved because the trial is a U.S.-only trial, but then everybody can, you know, go around the world and be prescribed that drug, then that helps everybody. So we're all interconnected in some ways, I feel like.
The other thing I would say is, if anybody else is, currently my job form, I speak English only. I have some conversational Spanish, and that's it. Currently it's only in English, but I have the option of having different translations. So if anybody really wants to volunteer their services to proofread what I could put through Google Translate, so we could put it into other languages and make it more accessible worldwide. I mean, my life is in the US, I'm US-centric, but I know that that is not the only place that MECP2 duplication syndrome exists. So if anybody is willing to read any of those or wants to help me, I would welcome it. I would absolutely welcome it. So,
Brilliant.
Helen, can I make a quick?
Go.
So Citizen was mentioned. So we put our first results out for Citizen in 2024. There's new results in 2025. I showed you a little bit here. We have a manuscript coming. I would like everyone in the room to know about the immense power of the data set that was built. It is jaw-droppingly incredible. And let me give you a few examples. So when we were talking about pleural effusions, I can go into that data set like tonight and say, how many kids had pleural effusions in the United States of that data set? What made them similar? When did they happen? How were they treated? And what was the outcome? Just like that. Just, right? You know, how many individuals of the population did it affect? Same thing. So this data set is extremely valuable to regulators because every point in it has a source. And so if I say for participant, 3, the seizure history on their 1,001st day of life was 3 seizures per day, and the regulator says, how do you know that? I can go and say, okay, here, all the way down, exactly here in the medical records is where the physician wrote that. And that is the entire child's life. We're only beginning to scratch the surface, and it has a very different purpose from a registry, and we are just beginning to tap into those successes, and unfortunately that's not possible in pretty much every other country besides US because you guys have privacy laws.
Fab.
Yeah, so caregiver report is not source data verification, unfortunately. Yeah.
Great. Thank you very, very much, Amelia. That was great. Thank you.
Thank you, guys.
We are... Sorry.